I would like to welcome all of you today in the Science Talk that's actually in King Salman Science Oasis. Today, the Science Talk is going to focus on in the pursuit to achieve optimal longevity. And we would like to welcome both Professor Jim Kirkland and Dr. Mahmoud Khan for this Science Talk. Just a bit of background on Professor Jim Kirkland. Professor Jim Kirkland is director of Robert and Arlene Cogdon Center of Aging in Mayo Clinic. He also is the president of the American Federation of Aging Research, and he's the founder of the Academy for Health and Lifespan Research. He specifically specializes in cellular senescence, which is one of the hallmarks of aging, and we're going to touch upon that in the next few minutes. Also would like to welcome Dr. Mahmoud Khan. He's currently the CEO of Evolution Foundation, but Dr. Khan was a faculty member of endocrinology at Mayo Clinic. He also served as a director of diabetes, endocrine, and nutritional trial units. So they're both from Mayo Clinic. Also, Dr. Khan served as the chair and chief science officer of global research and development in PepsiCo, and he was also the president of global R&D in Takeda, and also the CEO of Life Bioscience, and he's currently the chairman of the board of Life Bioscience. So I would like to welcome both of you today. We just want to start off, so everyone in the audience and people that are actually, I think we're streaming online too, just to understand aging and the science of aging and how aging is actually directly related to chronic diseases. And how does aging contribute, or understanding aging contribute to extending healthy lifespan? So I would like to start off with Professor Jim Kirkland to touch upon or make people understand further the meaning of, or the science of aging.
Yeah, thank you very much. And I'm very grateful to be here. I've had a very exciting visit so far and excited to be working with the people at Evolution. Aging has become a very fascinating field. I started off as a geriatrician, a specialist dealing with older people. And I got tired of prescribing better wheelchairs, better walkers, and wanted to do something fundamental about this. Also, like Dr. Khan, I'm an endocrinologist, so we share that. And then, so what I did was I went back to school and I did a PhD in biochemistry and began to ask, along with colleagues, what are the drivers of fundamental aging processes, and could we, by understanding these, develop interventions that would go beyond anything else to try to improve health span. Now, a couple of things about aging. Aging begins at or before conception. Down syndrome, for example, is an age-related disorder that is provoked by some of these fundamental aging processes. Children who've been treated for cancers with chemotherapy or radiation, some of them can develop an accelerated aging state a few years later. Women who have high blood pressure and a condition called preeclampsia around pregnancy, this is related to escape of aging-like cells from the placenta in the developing baby to the mother. So fundamental aging begins at or before conception, and these fundamental aging processes can be root cause contributors to multiple chronic diseases and disorders. And amongst these are Dr. Prakash at Mayo, who's chair of physiology, for example, discovered that when babies have to be resuscitated just after birth with high oxygen, this can cause acceleration of aging processes in the lung that result in asthma when the children become 2 to 4 years of age. So, and of course, fundamental aging processes contribute to things like Alzheimer's disease in older populations, to frailty, which is a huge problem with loss of muscle mass and difficulty getting around, to predisposition to cancers, to predisposition to heart disease. In fact, for most of the major chronic diseases, aging itself is by far the biggest risk factor or predictor. So if you look at the risk of having strokes or heart attacks, the increase in risk of strokes and heart attacks caused by having a high blood sugar, a high cholesterol, a positive family history, a high blood pressure, is 2 to 4-fold. But if a person is 85 versus 30, their risk is increased 1,000-fold. And it goes down the list like this, so that if you draw bar graphs and you look at predictors or risk factors for the major diseases that account for the bulk of morbidity, mortality, and health costs, you don't even see the other risk factors if you put aging on that bar graph, because it's such an overwhelming risk factor. And what the field is about now is not trying to extend lifespan at all costs. People don't want to live to be 120 and feel like they're 120. The idea is to improve health span. That is the period during life when people are feeling well, are living independently, are free of pain, can think in a lucid way, can continue to work and enjoy work because they become more senior and more visionary as they learn more. And can we do that? And in experimental animals, yes, we can. And in fact, what we even find in experimental animals now, with the 35 or more interventions, that classes of interventions that look like they impact on fundamental aging processes, we can rectangularize health lifespan curves. In other words, we can improve health span. And the goal would be, because we can do this now in mice and arguably some other species, would be for people to be able to work, to enjoy their life, to play sports, and then maybe when they're 90, 95, 100, just not wake up the next morning. So, and not go through a period of disability at the end of life. Indeed, people who die at around the age of 100 and are genetically predisposed to live to 100, healthcare costs in their last 3 years of life are 1/3 the healthcare costs of people who die at the age of 70. So there is something about these fundamental aging processes and targeting them that could affect everybody right from birth through to advanced old age, and could really prolong the period if we're investing in people getting an education and they're 35 or 40 by the time they're a fully trained professional and have all their degrees. If those people could work longer and enjoy life and contribute, our investment in their education would be greatly extended. Now, it's turning out that targeting these fundamental aging processes goes way beyond healthcare even now. We're finding that spaceflight, for example, is associated with accelerated fundamental aging processes due to radiation and zero gravity and other effects. We're finding that astronauts are getting age-related conditions earlier than other people. We're finding people exposed to radiation for cancer treatment, but arguably also if there were a nuclear accident or something. We need to develop some of these interventions to mitigate the effects of radiation, which is to cause a process called cellular senescence, which drives fundamental aging mechanisms. There could be applications in agriculture. Imagine what we could do for sub-Saharan Africa if we could have cows producing milk longer, or chickens laying eggs longer, or sheep growing more wool that has a better color. So the applications are way beyond what I ever thought. We're doing work now with the groups in Harvard and in Holland, looking at rehabilitating organs harvested from older donors for transplantation that currently are thrown away, to try to restore the function of those organs before they're transplanted into people. Mm-hmm. At the moment in the United States, we're throwing away 35,000 kidneys every year from people who've offered to donate their kidneys who are over 50, just because we know that if you transplant organs from older individuals into younger individuals, those organs don't do very well and are likely to be rejected. It's turning out in preclinical studies in experimental animals, we're able to rehabilitate those organs before they're transplanted. So me going from a geriatrician looking at having to prescribe wheelchairs and walkers to now seeing that the field has moved to the point where some of our greatest stars are in pediatrics, looking after children. where we're looking at trying to reduce the negative effects of cancer treatment and improve cancer treatment, to thinking about astronauts and pilots, to thinking about agricultural applications, to thinking about what could happen if people could donate all their organs upon their death, and those organs would live on in other people. So in a way, they would be living on. I mean, the applications are just boundless. And I really think Dr. Khan is a leader, and I think the royal family here has been really visionary in seeing the potential of this, which has only really developed over the last 3 to 5 years and could take off. And I'm hoping against hope that all of this stuff works. We're in early phase clinical trials now with some of these interventions. It's high risk, but high potential reward. We don't think people should be taking these sort of interventions at the moment, or physicians prescribing them, until we do carefully controlled clinical trials. But we're at that phase at the moment. So it's a very important, very critical phase where I think I like the term evolution because it's got evolution in it. This could almost be a next step in human evolution. So I'll pass over to Dr. Khan.
Thank you so much, Professor Kirkland. I don't know, Mohammed, do you want to touch upon that, or we can...
Let me just briefly build on it with three questions, then I'll hand back to you. I see a lot of young faces in this audience, which is great. And so it does raise the question, why would you be interested in aging and the whole field of aging, you know, when one's in one's 20s and 30s, which was a long time ago for Jim and I. Let me just touch on that. First of all, and then second is, you know, why is this of interest to Saudi Arabia? And why is it that Saudi is in the process of becoming the epicenter and one of the global leaders in this space? Well, first of all, this is the first time in human history on the planet that there are more people over the age of 65 than there are under the age of 5. Just think about that statistic. It has never happened before. And every society in the world just about has what we would think about as a pay-forward system. Pay-forward meaning, as one gets older, it's the next younger generation that takes care of the older generation, either by paying taxes indirectly or directly taking care of parents and grandparents and loved ones. So every young person in this room has that situation. However, when the number of older people starts to exceed the number of younger people in the world, fewer and fewer younger people are taking care of more and more older people. And if we continue our systems, society, engineering, infrastructure, communication, financial systems, for those of you interested in finances, insurance models, all of these in the old way of thinking, then there is not sufficient resources in any country, both from a manpower point of view, an infrastructure point of view, or financial point of view, to actually provide the care that's necessary. About 80% of most healthcare in advanced developed countries is actually age-related diseases, not taking care of the elderly, not the same thing, but diseases that are related to aging. Whether it's diabetes, and if you unfortunately develop diabetes in your 30s, or cancers that are age-related, developing in the 30s and 40s, or Alzheimer's in the 50s and 60s, these are age-related diseases occurring, unfortunately, in many societies at a younger age. So there's a double-edged effect. One is the population succumbing to these diseases. The second is the current models not being able to take care of this as we move to the future. One other thing that we should think about for Saudi, which is one of the reasons the RDI and His Royal Highness and others have been thinking about why should we be focused on this? The birth rate in this country has fallen to just above 2 now. The replacement rate is about 2.17, which means we are just touching the replacement rate. What does that mean? It means in the next 20 years, this young population that was assumed to be there to be taking care of an older population, that's not going to be there. As a result, even our social infrastructure, which, Jim, in this part of the world, and I come from the same culture, the notion of putting your mother in a nursing home is sufficient to being kicked out of the entire community. I could use other words, but I won't. But I would like to see the son who successfully puts his mother in a nursing home. It's about not going to happen. And so how are we going to take care of individuals who have got older but are not functionally able to? Now come back to Jim's comment. We've done a wonderful job of extending life expectancy from around 50s to 70s. But if most of that extra 20 years is spent in functional decline, then the quality of that life hasn't paralleled the expansion of that life. And the only way you can really change that is either support them with the environment that they live in, engineering, communications, sensors, devices, which we have to really think about as a community, or we change the biological process itself and help ideally sustain and prevent that decline, or even better, reverse it when it has happened. And in order to do that, you're going to have a multidisciplinary global initiative with clear vision, clear leadership. And Hevolution actually has been launched with exactly that in mind, to bring together the best minds, to provide that vision, provide the talent, people resources, and financial resources, and bring about, convene those experts to say this future is not simply an extrapolation of the past. So I just wanted to be clear, because often we get into these discussions and say, okay, you know, I'm an undergraduate, I'm in high school, I'm in graduate school, why should I be worrying about age-related disease? I'm going to get 40 years from now. Trust me, for those of us who are in their 60s, it seems like yesterday we were 20. So it'll come.
Thank you, Dr. Khan. I think we reflected perfectly the importance of understanding the science of aging, its relationship to chronic diseases. But I think the audience is really interested. Does this actually work? Did we actually see any success in the science of aging? Is it scientifically feasible? What has been developed up to now that can shed the light towards the future?
So let me kick that off, and Jim has been thinking about this field for several decades, and in particular, one of the hallmarks of the process of aging. But I'll speak from a global perspective and a business perspective. Since the last 20 years, I've been, I guess, running businesses and thinking about how to bring things to market. Because ultimately, I would say nothing really changes until every invention that happens in universities and laboratories actually ends up in the hands of the end consumer, whether that's a patient. And I like to think about consumers, not patients, even though I'm an endocrinologist, because we think about, you know, we are patients at some time in our life, but we are consumers throughout our life. And there's an important distinction. And if we're really going to be successful, we have to think about our consumers who consume this knowledge and treatments throughout life, not just when they're sick. So if we put that lens on, then it becomes clear, where have we come? Actually, this field of aging research is not new. It started almost 100 years ago. And like any invention, and I'm going to give an analogy, everybody's heard of the COVID vaccine and the brilliant things, and some of you have heard of CRISPR and the ability to edit genes, and how much progress we've made in the last 10 years. Let me remind you that the DNA, the structure of DNA and the double helix was 70 years ago. It was only about 20 years ago, 50 years later, we sequenced the human genome. 20 some years ago. And then about a decade ago, we started to understand the regulation of the details of this transcription, and CRISPR came along. And then in the last decade, we've applied all of that learning to real-world uses, which resulted in the COVID vaccine. So a lot of times we hear this, look at this current generation of rapid innovation. Look, we were able to develop the COVID vaccine in 9 months. No. It took 70 years. We applied it in 9 months. Now take this. Aging is actually, as a science, right at that cusp. The last 60 to 80 years, the underlying biology has been very thoroughly dissected. There's a lot more to do, but really we've started to understand. A lot of it because of pioneering work, like people like Professor Kirkland. Then in the last 20 years, we've started to now see that it's not just cells and worms that can live longer, but it's mice, it's primates, it's monkeys. And we're starting to see indirect evidence from observation and extrapolation even in humans. We're starting to understand how treatments work. So it's a bit like if you ever watched American football, of that 100-yard line, we're at the 90-yard line. And the question is, are we going to be like the Minnesota Vikings, my team, and drop the ball at the 90-yard line, or are we going to punch it home? And right now, I look at it as that analogy, and the science is there, understanding the mechanisms is there, understanding the pharmacology is there, but the last part, which I think is the key reason I have confidence, is for the first time historically, we can collect large amounts of data in distributed populations, in real time, and importantly, analyze that data in rapid ways using computational capabilities which we've never had, and translate that into diagnostic capabilities using technology that we didn't dream of 10 years ago. For example, and this is something that I'll hand over to Jim to talk about, but imagine if I could tell you that your biological age and its cellular function relative to your age, because we're all aging at different rates. Some of us, we may all be in calendar terms the same age, but in biological terms, we're all aging at different rates. And so if we could determine on a chip, and I'm throwing the challenge out to our students here, on a chip, where you could use that chip to diagnose exactly what your age is biologically, and it could tell us computationally what the best way to intervene is, right there in the doctor's office, or maybe even in your own home, that would revolutionize how we think about preventive health care, as opposed to, I'll check your blood pressure once a year, and if it goes up, I'll give you a treatment. Important, because I used to do that for many years. But clearly it hasn't been enough. So, Jim.
Yeah, thanks. And to take a step back, it's been discovered that there are these pillars or fundamental processes that drive aging and multiple diseases throughout the lifespan. And it turns out these various processes are all tightly interlinked. So there's a process called cellular senescence, which I've been interested in. These senescent cells can cause a lot of damage to cells around them. They don't die easily. If you transplant small numbers into mice, you can make them age faster. If you get rid of senescent cells from experimental animals using a new class of drugs called senolytics or genetic approaches, you can delay, prevent, alleviate, or treat at least 70 different major conditions in experimental animals that are moving through to clinical trials now. And the same is true of the other fundamental aging processes, like decreases in things called NAD, some people might have heard of it, changes in reactive oxygen species, changes in the way organelles work, like mitochondria, changes in DNA structure and function, and so forth. These processes are all tightly interlinked. If you intervene against one of them, you tend to affect all of the rest, the unitary theory of fundamental aging processes. So multiple ways of targeting these processes, both with new drugs, with repurposed drugs, with natural products, and with lifestyle interventions, appear to be effective in experimental animals. There are very early clinical trials now underway. One of the things I have the privilege of leading is something called the Translational Geroscience Network in the United States. So that's funded by the National Institutes of Health. And it includes Mayo Clinic, Harvard, Hopkins, Universities of Texas, Michigan, Minnesota, Connecticut, Wake Forest, St. Jude, City of Hope, Northwestern, and many others. And we're hoping to expand that, and we're collaborating with trials that are now underway in Denmark, in Holland, in Sweden, trials about to begin in France and Britain. So these interventions are actually in the process of being in very early phase clinical trials in people. And therefore, a range of conditions going from frailty in elderly women to cancer treatment, to looking at childhood cancer survivors, to bone marrow transplant survivors, etc. I went through some of these before. But there are going to be multiple ways of targeting these conditions. We know they're effective in experimental animals. And one thing about aging processes, unlike some other diseases which are species-specific, these fundamental aging processes are conserved across the vertebrates, from fish up. And some of them, like cellular senescence, you even see in invertebrates. So the hope is that if you can successfully treat fish or flies or mice or monkeys with these things, there might be a greater chance we can translate them seamlessly into humans than, say, a condition like Alzheimer's disease, which only occurs in humans, one form of chimpanzee, maybe dolphins, and is very hard to model in experimental animals. So there's that hope. I don't know that this will actually occur. These trials are underway at the moment. They're double-blind, many of them. The codes aren't broken on them. We don't know who's been treated and who's in the control groups. Some early initial trials have had some very promising results. But I lie awake every night worried that there's going to be a side effect or something like that. We don't know. Anything that sounds too good to be true often is. And that's why we need to fuel the drug discovery pipeline using some of the methods that we found that works and fund basic science in this area. I think an opportunity in Saudi particularly is looking at some of the natural products that exist. So some of the most effective agents, senolytic agents, that selectively kill senescent cells while leaving other cells alone are flavonoids, things like fisetin, which is in strawberries, but you'd have to eat 6 kilograms of strawberries in 5 minutes to get the dose that we give of senolytics. One nice thing about treating senescent cells is they take time to form and they don't divide. So we can treat people intermittently. So in many of the clinical trials, people get doses of these agents once a month. They don't have to be given every day. So the whole regulatory framework has to be different than what we normally think about with the old-fashioned one drug, one molecular target, one disease approach. This is much more like developing antibiotics, where you may use a range of interventions. You're going after a cell type. In the case of antibiotics, maybe a bacterium. We're going after senescent cells or aged cells. And you're going after multiple diseases, disorders, and conditions. In the case of an antibiotic, you may be going after urinary tract infections, heart infections, meningitis. The same with developing senolytics or NAD precursors or sirtuin agonists or many of the other interventions we have. We're going after multiple conditions. So we've had to rethink, how do you approach the regulatory agencies? What are the rules that have to be developed? So there's a lot of work to be done at the regulatory, the government, the drug approval, the pharmacology, the drug industry levels. So there are a lot of things that all have to come together, and I think that's where this science oasis kind of environment is very important, is to bring everybody together, from the basic scientists to the clinicians, to the regulators, to the people who provide finances, to try to pull this off. And it's going to take very much a group approach. And I think the culture here within this country is very much aligned with taking group approaches rather than people being in silos and competing with each other. So this field is a paradigm of how, it's a key example of a field where a collaborative approach is necessary.
Thank you very much. I think you touched on something very important, how understanding the science of aging can affect multiple elements in healthcare and healthcare system. Just want to understand a bit more, how does understanding the aging science or research or outputs from the aging science research affect policy making in terms of healthcare? How does it actually impact it? Will policies change if you understand further the science of aging? And how will it impact it locally and internationally too?
Let me, if I can lead off with that. First of all, our regulatory environment has evolved for good reason. If we think about the US FDA and other similar agencies, they essentially evolved to manage risk. The earliest days, there was really no clear definition of efficacy. If you go back pre those eras, and the policies evolved over time to make sure that the science on therapies brought to markets were validated and shown to be safe. And I think a lot of what you just heard Professor Kirkland talk about is we know many of these treatments work, but now we have to not only show that they work in humans, there's good reason to believe that, but we've got to show that they're safe. Because that's been, and the easiest way to do that from a science point of view is a regression approach. Control all variables, take one variable and try and do that. And yet, what you just heard is actually not a regressional approach, but can we treat with a matrix and still decipher, is this a safe mix? As an example, that's just an example, the regulatory environment is not yet ready to understand how to handle that, because it was developed at a time, as I mentioned, when computational capabilities, experimental design, all these things were not where we are today. What's it going to take? It's going to take a rethinking of what are the endpoints of biomarkers. If you're going to do an aging drug and you're going to show that people just live longer, you're going to take a 50-year trial. It's a 50-year experiment. That's completely unacceptable. So in the absence of doing that 50-year experiment, what is the endpoint that we could use? In determining that, we're going to have to come up with those endpoints and therefore markers. There's a whole set of work that has to be done. Parallel to that, we have to ask ourselves, what is the future of experimental design using statistical models and mathematical models of today, as opposed to historical, straightforward, simple randomized trials? Maybe other variants of that. But then the policymakers got to accept those designs, and it behooves this dialogue to occur. And then ultimately, as we think about the environment around intellectual property and policy, what are the incentives we're going to create to incentivize the private sector to actually invest behind this? And this is public-private partnerships. Because if we use today's model and the current policy environment, if you're a young entrepreneur, you say, really, I think this is a huge, and it is a huge global business opportunity, just given what I just said. This is not the time globally to be shifting most of your resources in pediatrics when the 65-plus-year-old population is literally doing that. There are 10,000 people in the United States that turn 65 every day. 10,000 people in the US alone turn 65 every day. That's a market. However, how do you incentivize getting behind that if you want to develop something that's a natural compound? Maybe it's something that exists in traditional Arabic medicine. And now you want to invest in it to bring it to market. If you use today's models, nobody wants to invest in it. One of my colleagues here, Dr. Bill Green, is a seasoned venture capitalist in this field, in biotechnology. He's not going to be able to raise money typically in a traditional model. Hence, you've got examples like Hevolution being launched, where our mission is to invest. But the impact of our investment is not just because this is the financial return. Yes, we will have financial returns. But will we move the field forward, and how do you measure? That's a very different way of measuring impact on investment than the traditional financial models we have, which comes back to policy. So I've just touched on several examples where we're going to have to move on multiple fronts, which is precisely why we need to have multiple disciplines. I'm not a financial expert, but we're going to need people with actuarial background, financial modeling background, computational background, people thinking about legal policy, IP in very different ways. And I'll leave it at this. It's going to take this next generation of scholars convening in this type of forum to say, let's think about this together, not just a group of biologists sitting there saying, I've just discovered this new molecule, now it'll work. That model is no longer sufficient in the day and the era that we're at. So, Jim.
And another thing that I think the world is moving from is disease care to health care. And what we're talking about with some of these interventions is actual health care and prevention, but also treatment of multiple conditions with an individual that occur at the same time. A lot of people who are older may have 4, 5, 6, or 7 different conditions beyond 5, 10, or 20 different drugs. When these fundamental aging processes tie those conditions together, we may be able to simplify treatment or amplify treatment. And we may be able to come to a point where we provide these interventions plus disease-specific interventions and get a synergistic effect. And some of these interventions are lifestyle interventions, some of them are drugs, but there's going to be a whole next round after the initial agents are tested and available in looking at synergies of disease-specific with these sort of fundamental aging process targeting agents. I think one of and there are particular diseases and disorders that could be targeted that it's never been possible to target before, like Alzheimer's disease, or in Saudi and the Middle East. I think a major problem that we've been talking about a lot is congestive heart failure. This is a leading cause of death in this part of the world, and there's one form of it that accounts for about half the congestive heart failure that occurs in Saudi Arabia, called heart failure with preserved ejection fraction, for which there is no good treatment. But it looks like in experimental animals, we might be able to solve this, at least in part. So I think there are conditions that are very prevalent in Middle Eastern populations that nobody's been able to address before, and there might be an opportunity here. So we're looking at treating multiple conditions at the same time in the same individual, or preventing multiple conditions from occurring. We're not looking at one disease at a time. We're looking at health care. And some of the key outcomes are going to be things like, can we improve mobility? Can we improve general capacity to work and daily activity? Can we improve people's ability to think clearly? So these are going to be some of the outcomes of clinical trials, and indeed in the clinical trials that are underway for specific diseases, because that's the model we have to use, we're adding in measures of these things. And I think what Dr. Khan was talking about before, coming up with biomarkers, and we like to call them Gerard diagnostics now, is going to be very, very important. So across the trials, we want to measure things in blood, in urine, in saliva, in buccal swabs, in nail clippings, in hair, in the microbiome, and also parameters like electrocardiogram. You can, with 99.5% certainty, you can tell if a person is a man or a woman just from their electrocardiogram using artificial intelligence approaches. There are new imaging methods, some of which are being developed here using infrared that are non-radiation inducing, that we could pull together into what we call composite scores using advanced computing methods to not only predict if a person's got a disease, not only, or will get a disease, not only to say what a person's biological as opposed to their chronologic age is, but also to tell us, as Dr. Khan was saying, what agents should we use, what lifestyle intervention should we use in that person to prevent things from happening, or if they have a problem, we have to find composite scores that respond to change with these interventions and reflect actual improvements that occur in the patient. And it would really one day be nice to have labs on a stick, on a chip, the chips on a stick, where we could, we call them centimeters. That's what we'd love to develop, where as Dr. Khan was saying, in a physician's office or a patient's own home, we might be able to say, we should give this intervention now. We can see if this intervention actually works. If giving that intervention causes a change, that's going to predict an improvement or not. Because different geroscience interventions, the different agents we've developed, some of them are going to be safe at different phases during life. Like, why would you give a senolytic to a younger individual who has no senescent cells? Conversely, why would you give an NAD precursor that makes cells grow faster and better, that may be very effective in a middle-aged individual, to a very elderly individual who might have cancers that are developing, and you could give them a selective advantage, the cancers. So we really have to think our way through all of these things, and we have to have Gera Diagnostics taken to the next level in order to move ahead.
Thank you very much. Just the last question, and then I'm going to give the chance for the audience to ask any questions. So, Dr. Mahmoud and Professor Jem, why evolution? What will evolution do to advance the field?
Okay, well, there are a lot of gaps in the field globally that need to be completed, and I think Evolution is a global organization. Its head office is in Saudi, but I think the vision is for it to be global. Things that are missing include priming the pipeline with new agents and interventions, but include especially identifying and training bright younger people who can see things from multiple perspectives. And one of the areas that we're really missing people in is people who can bridge what we call the valley of death between late phase preclinical work and actual clinical intervention. So there might be just a few more than a dozen people who are specialized in geriatric medicine in the world who also have PhDs in basic science and can understand the preclinical side of things. Mehmet and I are both endocrinologists, and I could say the average endocrinologist, specialist in endocrinology, could probably walk from the bench into a laboratory and do a PCR reaction. The average geriatrician cannot, because I'm also a geriatrician, and my colleagues just can't do that because these things have never existed before. So geriatrics is behind other areas, and we need a trained workforce of people who understand clinical trials methodology, basic science, and aging. And so we need a new generation of people who are trained. There are technologic things that need to be developed. We need to think differently about AI approaches, or think differently about drug screening approaches, or development of libraries, or natural products, or how we actually test these things in screening systems than we ever have before. We need to have medicinal chemistry from people in specialized in the aging field. So all of these disciplines need to be modified, and there are just many more gaps than there are things present if we want to push this stuff forward. And I think evolution can step in and fill some of these gaps.
Let me just, and I'd like to hand over to the audience, but you heard Professor Kirkland explain the gaps. And then let me bridge that, then therefore, why does evolution have a right to succeed? We're clear on what the gaps are, but the reality of it is, if you really put this together, it's not just that there's a deficiency of resources, financial and human, which are, to me, the enablers, but they're like any major undertaking. If we want to put the equivalent in health of a man on the moon, it's going to take a convening of the best minds, a clear vision of what we want to achieve, a clear idea of what the resources are it's going to take, and then to catalyze and incentivize that collaboration around the world to come to it. The role for Evolution's headquarters, being in Riyadh, is to be that leader and to bring about the convening, the acceleration, and then ultimately the impact. And what we're committing to is measuring our success by increasing the number of treatments that come to the market and accelerating the timeline of their appearance into the market, compressing all of the research and development time it takes. We saw a global effort with COVID. We've seen a global effort around initiatives such as putting a man on the moon. We saw a global effort of sequencing the human genome. Whenever we've had major breakthroughs that have impacted every person on the planet, it's taken that type of convening. And so to us, the Hevolution team, we're actually privileged. It's a privilege and an honor for us to have the opportunity to convene that thinking, accelerate that thinking. And personally, what keeps me up at night every day is there isn't an opportunity on the planet that if we're successful, will touch every single living human being on the planet. There isn't one that I can think of. Perhaps you could think about environmental changes, but this one touches every single person in this room and every loved one that we've ever touched, and even the ones we don't. So let me throw that out as questions for this audience and others.
So please, any questions?
So thank you all for your talk, and it was a very enriching and informative one. As someone who's passionate in neuroscience, I come to think of the brain usually as the organ being harmed from aging. But I can also view it as the cause of harm because of the, well, it might sound a pseudoscience, but as the placebo effect and how mental health can affect aging dramatically, and how can understanding the brain and linking it to aging will help in achieving optimal longevity.
Well, thank you for that. Let me kick that off. And I think Jim and I, Professor Kirkland and I can come at this from different perspectives and the same perspective. As a clinician, we know that mental function has a clear impact on the rest of the body's physiology. We've known this a long time, whether it's through stress and its impact on physical health, the impact on cognitive capabilities and vice versa. We now have progressed further than that, and not just neural connectivity and communication between the brain and the rest of the body, but we now know that communication not only is endocrine, but a gut-brain reaction, connection, and potentially a microbiome and bacterial brain connection. We realize we've learned this as endocrinologists decades ago when we realized that insulin release from the pancreas is anticipated by the pancreas through connection with the brain even before sugar appears in the blood. This is not new. We learned this as medical students. However, the interesting thing now is, as we see the aging process occur in the brain, to date we've been abysmally failed at providing treatments that can change that. I think if any organ system has been underdeveloped therapeutically, it is the brain. If we think about any of the other organ systems, we've probably got a better understanding. In particular, because the human brain has that much more complexity than many other, even mammal, with some exceptions, mammal. So this leads us to what can we do about it? We have evidence, and I'll hand over to Jim on this, that the same aging process at a cellular level that's occurring in other tissues is occurring in the brain. We also recognize that impacting those pathways, at least in animals, is likely to have benefit. Where do we go from here? There's three parallel paths at a macro level. One is understanding mammalian brains other than humans and learning the biology of the human brain from those models. The second, which I think is going to be more difficult than a lot of times engineers think, is to model the human brain. And right now you have the Blue Brain project you probably know about in Europe, modeling the mouse brain. But there's one important difference in the human brain versus any circuit. Mammalian brain circuitry is dynamic. Cells create connections and then change connections in a dynamic way. Physical neural networks are fixed. So until we can model that, the computer model of the human brain is far from being close. So we need to think about, which means engineers are going to have to think about computational circuits in a very different way than the traditional silicon chip fixed circuit that we're thinking about. And they're trying to model that through multiple layers and all the rest of it. And then finally, how do we think about pharmacology when we're treating brain disorders and yet we're not delivering drugs into the brain? We're delivering them through a series of barriers, starting with either the periphery in the gut or the gut itself, right? And so I've given you all the problems we're going to think about because you've asked the question, how do we do? This is going to take, again, lots of different disciplines to come together and say, we will work on this together. This is not the old, I'm in my lab, I found a drug, I'm going to find it. That's not going to work.
Thank you.
Yeah, it's very interesting. The brain is connected to the body, and of course the body is connected to the brain. So it looks like in the case of these senescent cells, for example, if you transplant senescent cells into the body of mice and they stay put and they're not in the brain, they cause deterioration of cognition in those mice and development of brain disease. So these things work in both directions. Also, it looks like multiple diseases are predisposed to by fundamental aging processes that are brain diseases. And so these include in experimental animal models, not just Alzheimer's disease, for which animal models are pretty bad, but also include cerebrovascular disease, amyotrophic lateral sclerosis, multiple sclerosis, spinal cord transection and injury, peripheral neuropathies, just basically everything, multiple sclerosis. And trials are beginning in many of those conditions, and in fact trials are partway through now. There are 3 trials for Alzheimer's disease, for example, with Senolytics, funded by the Alzheimer's Association and Alzheimer's Drug Discovery Foundation. And there are also trials beginning for mild cognitive impairment with senolytic agents in collaboration between us and the group at Harvard. So we'll see what happens. Those trials are underway. The results are very, very promising in experimental animals, of course, or the Food and Drug Administration in the United States and the IRBs, the institutional review boards, would never have allowed us to start those trials, and we never would have got funding. But those trials are actually underway. And even in humans, there's early evidence, not yet published, that peripheral senescent cell burden is associated with senescent cells that you find in spinal fluid. So these processes are body-wide. It's turning out the immune system is another important focal point. So a collaborator of ours had an important paper in Nature just recently, and she's at University of Minnesota, which Dr. Khan has had a lot of connections with, where they found that by accelerating senescence in the immune system specifically, using genetic models, caused brain dysfunction and caused body dysfunction. So even targeting the immune system, there's a link between the brain and the rest of the body that looks exciting. And this is the classic immune system too. This is the classic innate and adaptive immune system, which get into the brain in addition to what happens with astrocytes and microglia. You know, because if there's breakdown of the, like all these diseases, there's breakdown of the blood-brain barrier. So the body starts, in the context of disease, interacting much more with the brain than when there's a healthy brain and an intact blood-brain barrier. So these things are getting very exciting, very interesting, and are reaching the point of clinical trials. And I just would give anything if we could do something about Alzheimer's disease, for example. So these trials are in people with fairly advanced disease, with stage 2 disease, to see if, not just if we can arrest progression, but maybe get some restoration of function. Because in experimental animals now, with some of these interventions that target fundamental aging processes, we're getting new neuron growth, even in old animals, and decrease in gliosis or fibrosis of the brain, improvements in microcirculation, and even in experimental animal models, as bad as they are of Alzheimer's disease, regrowth of the cortex and restoration of executive and memory function. So I'm hoping against hope, but if some of these things could work in people, just if any of these trials worked, you could imagine what the implications would be.
Thank you very much. Any further questions? I think one more question or two.
Okay. My question is, actually I have two questions. One is from also an online audience. My question is, do we have currently aging biomarkers that exist currently?
Yes, there are. There are individual biomarkers, and then there are composite scores that have been developed. And Dr. Khan and I were at an important meeting in Bethesda in Washington, basically, talking to a large group of scientists, investors, companies, and the regulatory agencies about putting together some of these things. So there are at least 30 or 40 individual biomarkers, and there are ways of putting them together in composite scores. And I think one of the things that would be exciting and came up at the meeting, I don't know if it'll come to pass, but maybe we could develop composite scores of biomarkers that everybody would accept and would be, in a way, non-proprietary, would be like internet protocols or like building a highway, so that these kinds of biomarkers could be used in clinical trials and by companies to develop products, much the same way as a government builds a highway and then trucks from different companies run on that highway and make money. So I was surprised, but some of the big pharma groups and some of the larger biotechs were actually interested in beginning discussions, at least, in pooling their material together and selling their intellectual property at $1, as Dr. Khan has had experience with in other situations, to whoever wants it, so that we could maybe create something like an internet protocol, because companies all use the same internet, and they got together and came up with an overall structure. Maybe we could do that with some of these geroscience things. It's a bit of a dream, but it came up in this meeting in Washington, and I was surprised that there seemed to be a lot of buy-in.
I just want to add one thing to this. From a regulatory point of view, we often think of the United States as the most, in many situations, we think of the US as sort of at the cutting edge of innovation, right? Not always the case in regulatory. If you think about some of the very, very important drugs we're talking about, metformin is a good example, calcium channel blockers, ACE inhibitors, angioplasty as an intervention, they were not first approved in the US for clinical use. They were actually approved in other markets, and then once they were shown to be safe and effective in those markets, over time came to the United States. One of the things we have to think about with biomarkers and their acceptance is not to narrow down on necessarily the largest markets in the world, but think about the most innovative markets in the world, and then think about scaling them from there. That's a different model than big pharma's been doing in recent past. So I just want to, even with biomarker acceptance, we have to think globally, not just as it sits today. Your second question?
This is from an online audience. Their question is, if evolution is going to be focusing on aging process to cure chronic diseases, then what are the roles of the pharmaceutical companies?
So we think of the pharmaceutical companies, and actually Dr. Bill Green gave an excellent talk yesterday at King Faisal Specialist Hospital. This is an ecosystem, and in that ecosystem are included academic labs, national laboratories like CACST or the US National Lab System, biotech startups, pharmaceutical companies, and of course all of the academic environment, universities, etc., specialty research institutes. We all play together. And in terms of the competition occurs typically within one sector of that, between themselves, but not as much between sectors. The role of government is to accelerate the science. And just about in every situation, government-funded research allows that intellectual property to be leveraged. The highway is built by the government, we all travel on it and make money from business. Pharma has a very important role in scaling up development and then bringing it to market. But as Dr. Green showed yesterday, 2/3 or so of the drugs that pharmaceutical industry is launching is coming actually from small to medium biotechnology companies. That's the partnership in society. May not be a formal partnership, but it's a sector partnership, and both have an important role. For us, Evolution, we will work with every one of the sectors that I just described within that ecosystem.
Thank you very much, Dr. Khan. Please, there's a question here also. Thank you.
Thank you for your talk. I had a question for drug design. Do you think it's better to have a drug that stops the process from happening, the damage, or to fix the damage once it happened?
You want to kick?
I'd say both are desirable, but in the case of some of these processes, these fundamental aging processes are there for a reason. They're protective. Evolution selects for things that help us. So something like cellular senescence, senescent cells, these cells that can damage cells around them, they're important during embryogenesis for remodeling tissue. They're important if there's a serious skin wound for, again, getting rid of damaged tissue. They form in the placenta, and they produce factors that drive the baby through the birth canal. They're important in preventing cancers from developing. So cancerous cells have mutations in them and upregulation of oncogenes and replicate rapidly, which makes them more likely to become senescent and therefore stop dividing, and also produce factors that kill the cells around them, which can be cancer cells. So in the case of senescence, for example, you would not want to stop that process from occurring. What you're better to do in the case of senescence is where senescent cells have formed, where they're persistent, where they're not removed by the immune system the way they're supposed to be, is to periodically clean them out if the immune system is incapable of doing that. Also, senescence can spread from cell to cell, both locally and in an endocrine manner. So if you transplant senescent cells into the distal, like into the abdomen of a mouse, you get senescent cells forming from the mouse's own cells in its arms and legs, because it can spread. So if you stopped senescence from occurring, you do cause cancer, and that's known. If you inhibit things called P16 or P21 or P53 or RB, you cause cancers to occur. But if you get rid of cells that already have upregulation of those things and are already cancerous or senescent, you alleviate dysfunction. So there's going to be a bit of both prevention, which would be things like preventing fundamental aging processes from progressing rapidly, like these could be dietary interventions, could be sleep interventions, could be various physical function and other kinds of interventions, as well as arguably various nutraceuticals and drugs. But you also want to have ways of, once those things have occurred, of reversing them or getting rid of them. So it's going to be a bit of both prevention and treatment, but it's not just a straightforward answer. You can't say, yes, it can only be prevention, because you can cause harm by preventing some of these processes from operating where they're needed, because they evolve for a reason. And on the other hand, you've got to be able to target these things once they have occurred. So it's going to be both. I'd say the answer to your question is both.
Thank you very much. Dr. Basma?
Go ahead.
Thank you. This has been very stimulating and very interesting. I'm just wondering, and I know that you said that clinical trials are really still very early stages, but when you think about clinical trials in general, things that are happening right now, the populations that are primarily enrolled in those clinical trials tend to be more from the white population. So I'm just wondering, when we talk about aging and research on aging and coming up with interventions to help in improving our health span, how would we ascertain or know that the trials that would be done, that would be conducted later on in as we progress through the clinical trial phases, that would be done in, for example, North America, would also give us here in the Middle East, specifically Saudi Arabia, the same sort of positive effects, if I may?
It's a great question, and in my former life, when I was running R&D for a large pharmaceutical company, it was a common question because we wanted to launch a drug for the world. We've made a lot of progress, and let me illustrate that. Countries like Japan require development for a drug, regardless of where else it's been developed, to demonstrate efficacy and safety within their own population, to demonstrate it in the Japanese population. China, similarly, has continued down that path. European Union has its own regulatory process which requires local debt. So all those are positives for that reason. The challenge actually comes when let me start with the US. What is a North American person? At this point in time in history, we're very close to the point where the so-called minorities as an aggregate now make up half, if not slightly more than half, of Americans. So the notion historically of studying Caucasian white is no longer really the case as we get more and more Hispanics, more and more, and in the United States you are required to enroll a certain minimum number of minorities for that reason. Saudi is going to be more complex for the same analogy as the US. While we think of Saudis as, and I'm as an observer, as a physician, as a nation, which it is, biologically, it isn't yet to be defined whether Saudis biologically are one nation. Probably not. Why? Because look around. Saudis are as diverse as many nations that I've come across, which is a good thing. But the challenge is, if you're going to study, quote, Saudis, you're going to have a difficult time saying, I've now understood what a Saudi is. In fact, the reality is, if we're going to do clinical trials in Saudi and trying to understand safety, efficacy, precision medicine, it's going to actually be more sophisticated than doing something in Sweden. Or even indeed Japan, which are relative to Saudi, much more homogeneous populations. So thank you for that. But this is going to be important as we think about the design of clinical trials. And in fact, part of what we're thinking about is evolution. Who is the audience we're studying?
I'll just add one thing. I've got 4 passports, so I'm sort of a world citizen in a bit of a way. And I'm originally from Canada. And the Canadian government has just put out a call for a $160 million program over 5 years that's going to look at interventions and issues related to aging. And a requirement, and there are groups of, it's going to be groups of universities across the country that are going to do this. Of course, in Canada, there's always the French population and the English population. They're not that different in a lot of ways. I'm a bit of both. But what they've required in Canada is that what we call the First Nations, in the US they call them North American Indians, we call them First Nations. There's a requirement that they not only be involved, but they be involved in the leadership of the whole thing. And there's a First Nations Council that has to be part of the trial and its leadership. And so that's going to be very interesting because the First Nations people and Caucasians are very genetically distinct. So I think many countries are beginning to think about this particular question.
Thank you very much. Thank you very much, great audience. Thank you very much for your informative session. I think people are now more aware about the importance of science of aging and how can it impact the decrease of chronic diseases across the globe, and I think solve most common diseases across the globe. So thank you very much. Looking forward to more sessions with all of you, and thank you. Have a good evening.
Thank you. I wanted to thank you very much too, and I just think it's amazing what Hevolution is doing and what could happen in this country. I think this country could be a real leader, and I think I've spoken to some very impressively smart people in the government here in the couple of days that I've been here, and I think the vision is just amazing, and I think the opportunity for the youth of this country in this field is going to be incredible.
Thank you very much. Thank you.